Hi, I'm Dr. Ken Iserson, and I'm your host for a series of 3 videos. When and why do we need to ration healthcare resources? And what is the ethical justification? How do we plan for and initiate healthcare resource rationing? And finally, who allocates the scarce resources? Describing how to identify, train, and use crisis triage officers to ration resources at the patient care level. That video also discusses how risk communication techniques can make the entire system run more smoothly in crises. Key points for this video are: who allocates healthcare resources during crises? How are crisis triage officers selected and trained? How should crisis triage officers function? And how do risk communication techniques, when employed through multiple communications media, maintain healthcare workers and the public's trust in crisis triage officer decisions? The first question is, who allocates healthcare resources during crises? Rationing scarce healthcare resources is not easy, especially when decisions must be made about individual patients. It's not enough to have a plan for allocating scarce healthcare resources. There must be previously identified individuals who are prepared to make these difficult decisions. The job requires the presence of clinicians who have the best available clinical knowledge, know what resources are on hand, and have been trained to allocate resources equitably. They must also have the authority to act and the full backing of the administrative and the clinical staff. The person responsible for performing this tremendously difficult task is called the crisis triage officer. This individual acts as the moral agent to ration available healthcare resources under an established plan. In the emergency medical system or pre-hospital setting, this crisis triage officer is usually the on-scene or incident commander. At the regional and national levels, where more general rationing decisions are made, is the incident commander or designate. In a hospital, the job of crisis triage officer should rotate among a trained and experienced group of people. In this setting, it is usually not the incident commander who has too many other responsibilities. Our second question is, how are crisis triage officers selected and trained? Away from hospitals, individuals in specific positions, whether or not they have the expertise, must often act as crisis triage officers by default. Within a hospital, crisis triage officers should be selected from respected members of the medical staff who have the medical knowledge and people skills to effectively and efficiently ration healthcare resources. To be effective, the pool of crisis triage officers must be designated in advance. This permits them to have adequate education and gain experience in their role. They become familiar with the disaster plan by practicing their role when resources are scarce but not critical, and during disaster drills. Over time, they learn to adjust their methods to deal with the real problems they encounter. Frequent interactions with their institution's bioethics committee helps crisis triage officers understand the ethical implications of their role and how to deal with allocation dilemmas. Our third question is, how should crisis triage officers function? Crisis triage officers allocate critical healthcare resources using the criteria of best outcome. That is, the amount of resources times the length of time they are needed. Decisions should be consistent with the best available clinical information and made in concert with the treating team and expert consultants. The final decision is never made by the patient's primary physician. The crisis triage officer is the most difficult position in any disaster response system. They must decide, based on available resources, which patients go to the expectant, dying category, when not to transfer patients, or even when to abandon patients if facilities need to be evacuated. To be effective, the crisis triage officer's decisions must be final. The healthcare staff and administrators must understand the crisis triage officer's role and be prepared to fully support their decisions, no matter how painful. During a crisis, each crisis triage officer should work for only 4 to 6 hours, followed by an 8 to 12-hour rest period without other duties. However, there must be excellent communication among group members, such as passing on a logbook at shift changes that contain vital details about situations encountered and decisions made. Crisis triage officers must operate under general utilitarian guidelines rather than rigid rules. Crises, by definition, are fluid situations requiring rapid, complex decisions. To be effective, crisis triage officers need maximum flexibility when making such complicated and painful decisions. Our fourth question is, what role does risk communication play in allocating scarce healthcare resources? Risk communication is a process to effectively deliver current information during situations that generate a fear of health or environmental risks. The audiences are healthcare professionals, staff, and the public. Trust encourages cooperation. In the midst of crises, people will be more willing to endure disruptions and to tolerate rationing of healthcare resources if they are kept informed about the situation. Using risk communication techniques is the best way to provide this information. Most people are afraid of the unknown. In a crisis, this fear becomes exaggerated. Most feared are events with delayed, irreversible, or man-made effects, those that have new, unknown, or unobservable risks, and global catastrophes. People also exaggerate the risks of events hyped by the media. Conversely, people tend to play down risks with which they are familiar. Risk communication helps healthcare workers and the public identify actual risks to themselves and their loved ones. It informs them what is being done and what they can do to minimize or avoid risk. Specific risk communication methods help break through people's fears so that they hear, understand, and remember the information being communicated. Specific ways to do this include delivering, in their order of importance, no more than 3 brief, clear, simple messages, repeating messages and using clear visual aids or demonstrations to help clarify the information. Because negative messages are always heard better and remembered longer than positive messages, limit their use. If a negative word, such as no, not, never, nothing, or none, is used, at least 3 positive statements should balance it. Successful risk communication also requires using the same appropriate, trusted spokesperson to deliver the messages. Choose an appropriate person for this. In fear-producing crises, people will not listen to the message unless they think that you care about them. So the spokesperson must be seen as caring and empathetic, which listeners determine in the first 9 to 30 seconds after they begin speaking. Spokespeople also must be seen as experts who are competent, honest, and dedicated. Risk communication should be implemented using multiple communication methods, including press releases, press conferences, public meetings, if safe, interviews in the newspapers and live on radio, TV, and internet, phone banks, email responders, websites, flyers, and fact sheets. Within institutions and organizations, risk communication should also be implemented through public announcement systems, closed intranet systems, in-house TV systems, and employee hotlines. The benefits of using risk communication in crises include that it increases cooperation if resource allocation is necessary, increases the likelihood that healthcare and support staff will remain on the job, and provides current safety and health information to the staff and the public. In conclusion, we must have not only rationing plans to distribute scarce healthcare resources, but also pre-designated cadres of trained and experienced crisis triage officers ready to make difficult resource allocation decisions with authority commensurate with their responsibilities. We must also employ risk communication techniques through multiple communication systems to provide information and to maintain the trust necessary to implement allocation plans during crises. This series of videos has shown that 1. Nearly every discussion of disaster plans calls for an ethical basis for resource allocation decisions, but few specific suggestions have been offered. 2. It is far better to make hard decisions about resource allocation before rather than during disasters. 3. Disaster or triage plans based on sound ethical principles must include equitable, not equal, distribution of resources, prioritize patients based on fairness and utility, have a moral agent, the crisis triage officer, to implement resource allocation. Both the medical and potential patient communities, stakeholders, must be aware of this plan and buy into it through community focus groups, and using appropriate risk communication techniques, establish trust and facilitates resource allocation and disaster management.